Bonjour, bonjour, merci de votre patience, merci d'être là. Nous allons commencer dans 30 secondes. Merci, merci à tous. Maxence Duault, directeur général de l'ESA, à vous la parole.
Bonjour à tous. The presentation will be in English, but as General Manager of ESA, allow me a few words in French. Chers partenaires, chers invités, chers amis, c'est avec grand plaisir que nous vous accueillons aujourd'hui à l'ESA Business School pour vous présenter l'aboutissement de la réflexion de notre centre de recherche, le CRED, sur la structuration du système de santé libanais depuis les années 1990. Avant toute chose, je souhaite rendre hommage par ces quelques mots à toutes celles et ceux qui ont rendu possible cette conférence et qui ont participé à la rédaction de cette étude. En particulier, un immense merci aux auteurs, le docteur Abdelmaoula El Chaar, directeur du CRED, Rima Saleh, et que, voilà, vous pouvez l'applaudir d'ailleurs, vous pouvez les applaudir tous ensemble, et Maria Bayeh, chercheur au CRED. Merci également à notre partenaire sur ce projet, MSD Levant et Afrique du Nord, et tout particulièrement à son directeur des affaires extérieures, M. Hassan Bibi. Merci beaucoup, cher Hassan. Je tiens d'ailleurs à souligner, cher Hassan, votre professionnalisme et votre soutien inconditionnel, d'autant que j'ai su, et je n'en doute pas, que votre enthousiasme a été un facteur déterminant de notre fructueuse collaboration. Merci beaucoup. Merci également à nos deux panélistes, Dr Mirna Metni, experte du secteur de la santé publique, puisque vous y avez consacré déjà 14 ans de votre carrière entre le ministère de la Santé publique et la Caisse nationale de sécurité sociale. Merci d'avoir accepté d'être l'une de nos deux panélistes. Et bien sûr, merci au docteur Nasr, directeur de l'Hôtel-Dieu de France, que l'on ne présente plus, mais dont je souhaite saluer ici l'action déterminée en ces temps si difficiles. Merci beaucoup. Enfin, merci à vous tous. Merci d'être venus si nombreux. C'est toujours un immense plaisir de se retrouver, particulièrement dans cette période post-Covid, même si ça fait quelques mois. Je suis en particulier très ému et très heureux de pouvoir retrouver ici de nombreux visages de nos alumni, de nos étudiants. Donc bienvenue à vous à l'occasion de cette conférence. Merci. Ce n'est pas toujours connu, mais l'ESA s'est engagée depuis près de 15 ans dans le domaine du management de la santé et a même construit, en étroite relation avec le ministère de la Santé libanais et avec l'appui de l'AFD, des programmes de soutien à l'action publique en matière de santé, en mettant à disposition son réseau et ses expertises. Nous participons ainsi, et depuis de nombreuses années, à l'amélioration de la démarche qualité au sein des hôpitaux libanais, et ce, en partenariat avec la Haute Autorité de Santé en France, mais également à l'amélioration des circuits de transfusion sanguine, en partenariat avec l'Établissement français du sang, ou encore à l'amélioration du circuit des médicaments en lien avec l'Agence nationale de la sécurité du médicament en France. Depuis quelques années, l'ESA soutient également et de manière plus directe le programme national de santé mentale libanais et accompagne même les équipes managériales de l'hôpital de la Quarantaine. En parallèle, ça fait déjà beaucoup, nous n'oublions pas que nous sommes avant tout une business school et que notre mission principale est de former les leaders de demain, y compris en management de la santé à travers notre master exécutif en management de la santé en partenariat avec l'Université de Paris, ou encore, depuis peu, le certificat que nous proposons aux professionnels de la santé, le certificat InnovHealth, que nous proposons en partenariat avec l'école polytechnique. Vous le comprenez, dans ce contexte, c'est tout naturellement que le CRED, notre centre de recherche, s'est saisi de projets de recherche en management de la santé pour finir par s'intéresser, naturellement, au système de santé libanais dans son ensemble. Le CRED n'est pas le premier, évidemment, à se pencher sur la question. De nombreux articles, des travaux et réflexions ont déjà été publiés sur le sujet, souvent avec brio, notamment par le ministère de la Santé lui-même. Mais ce rapport, il a l'ambition de compléter ses prédécesseurs dont il s'inspire, et ce, avec une originalité fondatrice, à savoir essayer de présenter un point de vue alternatif à celui des spécialistes du secteur de la santé, grâce à une réflexion fondée sur les savoir-faire d'une business school, et donc porteur d'une vision spécifique, celle des sciences de gestion. Notre positionnement est simple, pas de solution hâtive, surtout pas à des problèmes complexes, mais bien la participation, l'animation du débat et la volonté de rappeler qu'il est indispensable, en particulier face à la crise terrible et souvent vitale que nous traversons, de poser les bonnes questions et de remettre en cause nos différents modèles. C'est peut-être ainsi, je l'espère, je le souhaite sincèrement, que nous contribuerons, parfois modestement, à l'émergence de solutions, et c'est en tout cas l'ambition d'une recherche-action qui se veut concrète, collective et même participative. Dans ce cadre, je remercie une nouvelle fois MSD Levant pour avoir soutenu cette recherche. Je tiens à le souligner parce que nous n'aurions rien pu faire sans votre soutien. Donc, une nouvelle fois, merci à notre partenaire. Et puis, merci bien sûr à nos deux panélistes, Mirna, Metni et Nasr, qui ont accepté notre invitation et que je suis impatient d'écouter leurs réactions, leurs critiques et leurs réflexions sur le sujet du jour. Je vous souhaite à tous et à toutes une excellente soirée et de fructueux échanges. Merci beaucoup.
Okay, yeah. Thank you so much for everyone attending today. So I'm going to speak in English. It's okay, I'm sure, for you. So on behalf of MSD, definitely would like to really thank you for the tremendous work that occurred, especially under the leadership of Professor Abdelmaoula and Thomas, and everyone who contributed directly or indirectly. I cannot really believe that we're here, Abdelmaoula, after all, and we're gathering to really share what really value for everyone. It was a very challenging time, but you made it with your efforts. Thank you so much. So let me take you a little bit through MSD. For the one who don't really recognize MSD, and for the one who recognize it, they will really be of valuing it more and more. So MSD, as you can see, we are driven by our purpose, to use the power of leading-edge science to save and improve lives around the world, and especially also in Lebanon and in the region. As you can see, MSD legacy began more than a century ago and continues today, from 1891 till 2019. And from this slide, you can see when the establishment happened for Merck and Co. in 1891, which is mainly known as MSD outside Europe and Canada. In 1895, when it was the first diphtheria antitoxin introduced, and you can see all through the century what happened, till we really reached 1997, where MSD forms the Genome Research Institute and joins the fight of rabies, contributing to the AFIA Serogeneity Project, with MSD contribution in mothers, where they established a program to reduce maternal death worldwide, and of course, lately in 2019, to fight Ebola outbreak. MSD focus is mainly on oncology, where we're working to invent a world where cancer isn't just treated, but also cured. Here you can see, and we would like to announce that more than 1 million patients who have been treated with commercially available MSD oncology medicines over the past 7 years. More than 2K clinical trials involving on cancer, our cancer medicine, and also 30% cancers that our products are being studied in. Our goal is to translate the breakthrough science into innovative technology, oncology medicine, to help people with cancer worldwide. The other pillar that we are really focusing on is vaccines. Our work focuses on making certain diseases a thing in the past. And here we are a greatest public health success stories in history within vaccine. Without vaccine, the world would have lost more sons, daughters, moms, and grandpas. And the latest one with the crisis that we faced in. More future teachers, builders, doctors, and inventors, and more people than an entire country the size of the US. Vaccines help prevent 30 infection diseases worldwide. And in the US, we make more than 10 of the 18 diseases on the CDC recommended immunization schedules, and where we distributed more than 188 million doses around the world in 2021. Last but not least, our hospital specialty and chronic care focus, innovating for patients with the hope of creating a better world. The hospital and specialty care is one of the current key growth pillars. We focused on finding solutions to unmet needs in HIV and infection diseases. More than 35 years committed to research to help combat the challenges of HIV epidemic. More than 40 investigators initiated antimicrobial stewardship funded across the globe. COVID-19, we're rising to the challenge. The COVID-19 pandemic is an unrivaled scientific and global health challenge. MSD has been fully committed to deploying an expertise to help address COVID-19, and we were really successful in it. We're advancing our pipeline, scaling up production, and working on approaches to enable broad global access. We're also applying our manufacturing expertise to help produce a J&J COVID-19 vaccine. We're committed to patients, and this is our main objective and our goal. That's why we pursue the best science in our invention and in anything we do. Every breakthrough we create has the potential to build a healthier, more helpful future for our people everywhere in the world. MSD is recognized as the most admired companies in 2021, as a Gender Equality Index in Bloomberg 2021, as a top employer in Europe in 2021, as a best workplace in Italy and Singapore, and inclusive top 50 in UK employers, and the most innovative companies, the Fast Company in 2020, and also Young Professional Ecuador and Colombia in 2020. Access to health is the name of the game. We do what we do, but the most important to have health equity across patients and to have access to health. Our responsibility to make medicines and vaccine and quality healthcare more accessible everywhere in the world. We take on diseases that rank high on the list of worldwide causes of death. We invested 96 million in 2020 in education for patients and, of course, providers. This is MSD. Thank you.
Merci. Et maintenant, pour rentrer dans le cœur du sujet, la raison pour laquelle vous êtes là, donc, professeur Abdelmaoula El Chaar, s'il vous plaît.
Good evening, everyone. Unfortunately, I will have to speak in English because my presentation is in English. Frankly speaking, I'm super impressed because, as my dean told you, I'm not a specialist of health matter. I'm actually a specialist in strategic management, and I'm speaking in front of a panel of specialists, so it's impressive. And then I'm speaking in front of my dean, so I should really be very careful about it. As Mr. Duault told you, there is a lot of material concerning the evolution of the Lebanese system. There are remarkable studies, especially published by the Ministry of Health. So the question is, find what's new. Eventually, if we can have an added value is, as Maxence told you, the fact that we are a business school. I'm going to be a little bit more precise about it. The added value is the fact maybe that I'm in strategic management. I'm a specialist of strategic management, and I'm working with very sociological theories. What I'm doing into this presentation is taking what I know, taking the theory of my field. We are talking about institutionalism, we are talking about institutional logic, we are talking about a lot of things that have very strange names, just to explain a phenomenon. And maybe the example of this mix is this title, A Health System of the Many for the Many. In my opinion, it reflects what the ministry tried to do, but also a health system of the many for the many is inspired by the Boston Consulting Group. This is the basis of adaptive leadership. And when you come to look at it, it's about tackling win-win, empathy, and autocorrection. If you make the liaison with the policy of the ministry, you see that actually they took in consideration the opinion of the stakeholders while trying to build the system. And we're going to go, to go a little bit in detail concerning that. They tried to create win-win situation with the private sector, win-win situation with NGOs, and then there was a lot of empathy. The strategic intent of the ministry was a healthcare for everyone. This is a strategy. This is out of empathy. And then they were very, very able to navigate the pitfall of the context. And we're going to talk a little bit about the history of our country. And wow, there was and there still is a lot of pitfall. In order to do that, the ministry applied something which was at the time rather new, which was collaborative governance. When you look at governance of health system, actually you have three big titles. You can be in the classic public management, meaning I'm the ministry, I centralize everything, I take the decision. And then at the opposite, you have new public management, saying there is a lot of inefficiency in the public system, so we're going to apply private-like rules. And in between, the new trend was, let's look at all the stakeholders, let's create systems that will be able to use all the possibility and all the potential of all stakeholders. And this is what the ministry done. By the way, I'm a super fan of Walid Ammar. I think that the guy is just brilliant. This approach is the doing of Walid Ammar and his team, and he was able, and we will see that, to put us in the 30th place worldwide in terms of quality of the health system. And when you come to think about it, it's remarkable. So we have that collaborative governance, and this led finally to resilience. Resilience is usually considered as the possibility of bouncing back, meaning that I receive a blow, I bounce back. Actually, it's a little bit more complicated. You have the bouncing back thing. This is the absorptive capacity, the possibility for a system to take the blow and absorb the blow. But then eventually, if the blow is heavy, if it's on a long time, the system should adapt, should adjust. So you go in adaptive capacity, and then following that, you have a transformation of the system. And the factors are definitely the intensity of the shock and the length of the shock. Till now in Lebanon, we were on adaptive capacity, and that collaborative governance was really a huge tool to adjust and adapt. And then we look back to my title, and the question is, Mr. Bibi was telling me, why do you put a question mark? That's enough. A question mark because since 2019, we are really in a super bad shape. The shock is enormous, the blow is enormous, and if we look at that question of shock intensity, in my opinion, my very modest opinion, we should transform. Again, if we look at the report that we have produced with my colleagues, the system is beginning to transform. Dr. Rima Saleh made a remarkable study on the evolution of the health system in the Shuf. Actually, we were finishing the study, and then we got the COVID, and we got the economic crisis, Hassan, and I talked with Mr. Bibi, and I should salute Mr. Bibi, because frankly speaking, and I'm opening a parenthesis, when Thomas is one of the people who made that project existed, when he told me we are going to talk with MSD, I told him, you know, Thomas, multinational research doesn't really mix. And he told me, just meet Hassan Bibi and then decide. And I should recognize that we worked with the full support of MSD and Hassan Bibi. And at one time, there was a tricky problem. And I went to Hassan, I told him, Hassan, what about that? And Hassan told me, Abdelmaoula, you are the researcher, you take the decision, we don't interfere, and MSD and Hassan never interfere in this study, and I wanted to underline that. So to go back to the study, at one point we were discussing, Hassan and I, saying, okay, we cannot say everything is nice and wow, the system is working, and we have the financial crisis, and we have the COVID. So I asked Rima, and Rima is one of our brilliant team members, to document the situation in the Shuf. And you spent, I think, 3 months, Rima, taking daily notes about what was happening on the ground, into the villages, into the hospitals, and how everything was reconfigured during the COVID crisis. This is why I'm saying eventually there is a solution. Talking with Mr. Nasr, he told me that Hôtel-Dieu, under the impulse of USG, is taking the responsibility of 2 other hospitals, including Saint-Charles. In the Metni, people are financing the system. So there is something moving. Is it good? Is it bad? Why? That will be probably the most interesting part of tonight's conference with Madame Metni and Mr. Nasr. We're going to discuss exactly that. This is our situation. This is the possible configuration. It seems that we're heading eventually this way. What do you think? How do we do that? Unfortunately, I was asked by many of you, you're presenting a solution. No, we don't have that arrogance. You're presenting recommendation. No, we don't have that arrogance. But what we can do is begin a conversation with you, and then eventually, if needed, ESA would be happy to host a think tank that will eventually talk about this kind of type of problem and try to elaborate, if not a solution, at least recommendation. But let's begin let's continue with that. So in order to elaborate the study, we did a longitudinal processual analysis. This is a very pretentious term to say that we took the history of the country and we sliced the history of the country. We tried to find what we call critical incident, to have discrete periods, and then with the team was studied what was happening during these periods, to have different configuration and try to understand why there was the change. So I'm going to begin with the brief history of Lebanon and the Lebanese health system, very brief actually. For those who are interested, you have a report where we develop a little bit the history. Then we are talking about the structuration of the modern Lebanese health system. We are using the expression structuration because it didn't happen in one night. It was completely emergent. When we take the report of the ministry, they says themselves, we didn't have a blueprint. We're just trying to create a system that will be able to heal all the Lebanese. And then we are going to look at the different configuration of the Lebanese system. And I'm going to present scenarios about the future of Lebanon very, very briefly. And then we're going to put the configuration in each scenario. And this is when Madame Metni, Mr. Nasr, we're going to discuss with you all about the future, the different configuration. Does it make sense? What would happen? What can happen? So this is what initiates the study. This table in 2017. That was a huge international companies and consulting firms saying that we were super wow in the health system. Remember, 2017, 1990, it's about 30 years. So in 30 years, we were able to go from rubbles, literally rubbles, to a system that was ranked among the best I was particularly personally happy about the first one. We were better than the States. Wow. So the question said, we are super, well, we Lebanese, how did we do that? And that was the beginning. That was the beginning of the study, and that was the proposal that we made to MSD, try to understand how the system transformed. So we began by looking at the history of our country. Very quickly, we got our independence. Then, as usual, there was war into the area. We even had some political clash that led to the intervention of the United States under the presidency of Camille Chamoun in Lebanon. But somehow everything was good. This is the time where Hamra was the Champs-Élysées of the Middle East, Beirut, le Paris du Moyen-Orient, and Lebanon, la Suisse du Moyen-Orient. And this ended in 1995 with the civil war. The war was really dramatic. We had a Syrian intervention. We have an Israeli invasion. We had in 1985 the end of the Israeli invasion, and finally, officially, in 1990, the end of the civil war with the ratification in October 1989 or November of the Taif Agreement, etc. So this is a very dark period, I guess, of the history of our country. 140,000 people were killed. This is official figures, probably much more. We had about 200,000 wounded, 800,000 people displaced, 25 billion of damage. It changed the configuration, completely the configuration of our country, with people going to their region instead of living together. This is the war. If we look at the health system, it was really super dramatic for the health system. About 1/3 of our public hospitals were either destroyed or looted, and about 1/3 of the public bed kept into action. And then reconstruction continued. Again, we had several wars with Israel. We had internal clashes. We have political lockdown, the usual, unfortunately. But we were able to reconstruct the country, and we were able to have a phase of economic dynamism. And unfortunately, that ended in 2019 with the first effective sign of the political crisis, and then we had the COVID, Beirut blast, and the Iraq, all those events, and this is where we are today. If we want to separate that in phases, we have actually, concerning the health system, the first period is the rise of the system. The second one is definitely the fall of the system, and it was completely destroyed, and we're going to talk about it. And then there was the rebirth of the system with this collaborative governance, and today, frankly speaking, unfortunately, nobody knows where we are heading and how we are heading. But let's see a little bit, let's try to understand what happened during each phase. I'm not going to go through events. I'm going to take the big titles, the main factors, and see how the system evolved. So the first phase is the reign of bureaucracy. We were getting out of a friendly, let's say, je sais pas comment le mettre en fait. On était gentiment colonisé par la France. Let's put it there. It was actually, when you come to think about it, it was quite soft. So, and we took all the system. Actually, we took all the system from the French. We created the Ministry of Health and Social Affairs that we didn't have. We established the first public network of hospital and primary care center. We began developing private health facility, but it was quite limited, because by the time the spending, and this is super important, the spending of the Ministry of Health vis-a-vis private hospital was 10% of the budget. So the ministry was just sending some patient to private hospital when his own facilities weren't efficient. Mirna, please, quand je dis une bêtise, tu m'arrêtes, tu me dis, t'as dit une bêtise. And then when we look a little bit about the configuration, it was the pure French command and control bureaucracy, which is not bad. And it takes this form. So it's classical public management. In the middle, we have the ministry, and you have all the function into the periphery that are controlled integrally by the ministry. And then comes the war. The destruction are huge. The ministry collapses completely, collapses physically, because hospitals are destroyed, cannot access facilities, and then collapses politically, and wasn't able anymore to work. And in parallel, there is a very sharp development of the private sector. We have an increase in health facility, and that the Ministry of Health is using abundantly, and the budget, the part of the budget, rises to 80%. Because by the time the ministry was paying, like it's doing today, the fees to heal the people that were going to private facilities, and because there was money, and there was a lot of money, there was behind that lobby, political lobby protecting the interest of private hospital they were themselves building in order to benefit from the subsidy of the ministry. And something else that was important by the time, and in fact, the guarant of public health were international organization that created or financed NGOs in order to help the people getting adequate healthcare, minimum healthcare at least, and there was another type of NGOs that were financed actually by a political party that found that as a good way to have more popularity, etc. So if we want to summarize, évidemment, it's a general situation. I'm not talking about all the hospitals. I'm talking in general. So if we summarize the situation, we have in the middle a Ministry of Health, which is somehow disconnected of the system and somehow helpless. Then we have private hospitals that are mushrooming in order to benefit from the subsidies of the ministry. And there is behind that the political parties lobbying to keep the situation as is and eventually increase the income of the private sectors. And we have the international organization with NGOs trying to provide somehow a security net for the people. What is interesting in that is not really that configuration. I found that the interesting part is these colored oval. It reflects what we call technically an institutional logic. It's a way of looking at things. These are belief, and with every belief, we have the association of practices. And when we look at these islands, we have actually three different institutional logic. If we want to summarize them, we have a market logic, which is the health entrepreneur that are using actually the health system to try to maximize profits. We have a sectarian logic. We are during the war, where we have warlords that are trying to maximize their power by lobbying, by eventually creating NGOs. And we have a pure healthcare logic, where we find the Ministry of Health and NGOs that are going for care maximization. if we look at it, the governance is a laissez-faire, and we are very famous in Lebanon with laissez-faire, which means try to maximize as much as possible your benefits with a minimal control, and every time we try to control that's no, it's not the regime. And then comes the end of the civil war, and this is the situation. The ministry is completely cut from the system. He doesn't have any information concerning the way the system is working, the way the billing is done, etc. And he don't have the technical means nor the political support to control the system. And then if we look at the private sector, actually they did represent at the time something like 95% of available hospital beds. What is remarkable that only half of it were used. There was an uneven geographical distribution, meaning there is no need to put a bed in Akkar where the people are poor, because the people are not going to pay for the bed. So the beds and the hospital were concentrated mainly in Beirut and some big city. There was an over-equipment of facility of high-tech equipment. If you look at the report, I think we had more high-tech equipment per people than Germany. Why? Because at the time, the ministry, the reimbursement of the ministry was done on technical equipment, meaning there was several grades of hospitals, and the more equipped you are, the higher you are, the more reimbursement you get. We had also the highest ratio physician to population in the world, meaning we had a lot of doctors. The hospitals were not able to absorb all these doctors, so they began opening private facilities for for healthcare and prime care system. Then comes the ministry, comes Walid Ammar saying, yes, I want to provide the population with universal and equitable access to healthcare. The guy was controlling nothing. I'm talking Walid Ammar, I'm talking the team. The team, and Walid Ammar make it more, which is not the case. So that was what the ministry decided. It was completely out of reach. But in my language, in my field, we call that a strategic intent, meaning this is where I want to head. I know that I don't have the means, but I'm going to head this way, and each time I have resources, I'm going to make sure that it is going in that direction. And this is what they decided to do, and to do that, and I think, but I'm not a specialist, but I think it was brilliant, because he said, okay, fine, we're not going to go from scrap. It is going to cost us $billions. He hadn't any budget. The ministry hadn't really a lot of budget. He said, okay, fine. What do we have around us? We have private hospitals who are going to use their networks. We have NGOs who are going to use their networks. And the results were that. J'espère que c'est le bon slide. The results were that. Actually, the ministry got back its centrality into the system. And I guess, and he was able to jumpstart the system without having to invest a lot of money. The black lines are official and formal relationship between the actors, and the gray one are informal relationship, meaning that there was a lot of conversation, and the ministry began, and I think you lived that, began to re-establish his power by going into a lot of study, a lot of capacity building to understand how things were going, how hospitals were really working, etc. Because when you want to control something, you just need to know how that thing is working. And this is what the ministry did during years. One of the very important part of the ministry plan were private hospitals. They decided, I guess, to build 12 new public hospitals. And they have, again, I think, a brilliant idea. And that brilliant idea was actually this law. The law 544 is saying that actually public hospitals are no more bound by the bureaucratic rules, that they have some autonomy, they have eventually a board that will take decision, and actually they have the possibility to cooperate with private third party. And I guess this is the brilliant part, because it meant that private hospitals were able to take resources outside the usual network of the ministry. And I'm going to give you an example. We're going to talk a little bit about Quarantina and the slim neonatal unit that was established by Robert Sassi. Dr. Sassi is not among us today. We did a case study at length with with Alia Khouri. We worked a lot on understanding how Robert was able, from one idea, just to build the system. The end result of Robert's action was that. So there was the neonatal unit. He got some financing from the SLIM Foundation, and because he got financing from the SLIM Foundation, he had the legitimacy to get actually financing for international organization, and somehow the civil society, he created an NGO that he called Hassan, and this is due to his reputation. And then because he was working at the Saint-Georges and had good relationship with Balamand, and initially Quarantina was working with the Lebanese University, he was able to pump professional expertise from these three universities. And then he got the support of civil society, NGOs, and finally he got the support for international organizations. So it's interesting because it was working, and if I'm not wrong, at one time this unit was considered as being the best neonatal unit in Lebanon. And people that they needed mean to go into fancy hospital were going actually at Al Quarantina to be healed by Robert and his team. So it is a success. And we talked at the time, it was before COVID and before the blast. We talked with the general manager of the hospital, and she told me, Karine Sakr told us, it's working quite well, and I'm thinking to replicate eventually the experience with oncology and psychiatry. So the idea was, Karine's idea was to find specialists like Robert that would eventually be a kind of hub between the hospital, specialists, etc. And then if we go further in that kind of thinking, that was eventually what the hospital would look like. The hospital would become a hub of expertise that was coordinating the expertise actually of doctors and other units that were actually getting support from outside the network of the public hospital. And if we zoom back again, we have that structure. It's very complicated. C'est juste pour dire qu'on a vraiment travaillé. Actually, I took only private hospitals just to see how it is going in different direction, being able to take resources from several and diverse stakeholders. We're talking about public hospital. Pharmacy is doing the same thing. I think that YMCA is an essential actor, and then all your colleagues and yourself are contributing. And if we go to each section and each unit, we have a structuration that resembles to that grape. So then the ministry got a new role. Actually, he wasn't really giving the service himself. He was using third party to provide the service. And he was able to do that because I'm not going to, je ne vais pas prononcer ça en anglais parce que je suis incapable, il a modularisé. Donc he sectioned actually the operation by discrete units, found specialists to take care of each discrete unit, and he just gave them the possibility to work. Actually, we call that technically orchestrator. And to be a good orchestrator, you need to have some coercive power. You need to have something that the other don't. And the thing that the ministry was having that the other needed was money. But the difference between this phase and the civil war, the ministry just built his capacity of control and was able really to see that the operation were going as needed. And concerning the NGOs, the deal was different. They never gave money to the NGOs. They gave them medication, trainings, etc., capacity building. So everyone was really happy, and the system was working quite well. And then came a famous 2019. I'm not going to expand on that because we are living that. We don't have one crisis. We have 4 crises, beginning with the financial crisis, the social-political COVID, and Beirut blast. And all the country, COVID is a catastrophe. Actually, our country was super prepared. This is why in the beginning we were able to control the COVID. But very quickly, COVID became the least of the worry of the ministry. The real problem was that. This is the evolution of the Lebanese pound from 1,500, and Thomas was telling me today that we reached 33,000. So just to see what it means that at one point, the ministry is reimbursing hospital at a rate of 1,500 and taking time. So hospitals don't have any interest anymore to work with the ministry, and that explains what I call at one point an upsurge of hospitals refusing to open COVID beds, saying no, we're not going to do it, and the ministry was not able to have any coercive action because he has no way to force them to do that. So that was the system, and this is when I asked Rima, and we discussed and had a lot of discussion with Rima concerning the evolution of the situation of the Shuf. And we discovered that. And that is interesting. You see, the ministry is no more the central actor. The ministry is becoming one of the actors. The PSP was injecting money into Ain Hussein that became a prime player, and it was already a prime player. Municipalities played their roles, international organization, and other municipalities that were financing actually NGOs. So you have what we call a distributed system. What is interesting, a distributed system, in fact, it's not even management, it's electronics, and it's computers. When they call about distributing systems, they talk about a system where if you remove one part, the system will automatically reconfigure itself to continue working. And this is actually what is happening. So if you look at that and you remove one of the parts, there's enough relationship between the other actors to eventually find a solution. I'm talking about the Shuf because we did that study, but I heard, and I don't have a study for that in many regions we have more or less the same configuration. There is, we says in French, la nature déteste le vide. When you have something missing, eventually you will have party going in. So this is where, in my opinion, we are now, and this is where eventually we can begin our conversation, because your reaction, okay, وبعدين? This is a good reaction. وبعدين what I suggest is to go using another instrument that we use in management, which is scenario planning. When you have the unknown, when you want to project yourself into the future, pourquoi il fait ça celui-là? Ah bah ça c'est bon, on va au revoir. You don't need that. Bon, so, sorry, I forgot that I had that slide. Actually, it's a summary of what we had. This matrix was built on, do we have a hierarchical governance, meaning a central node that is going to give orders, or we have more collaborative governance, and then do I have means or not? And if we put our figures on that, if you have the money, if you have the resources, and you have a very centralized hierarchy, actually you have new public management. If you don't have the means, but still you want to have a very centralized system, you have a public health spillover of UN and NGOs activity. They are taking the relay, the central node, the ministry is not able to do the proper job. If we go on collaborative governance and resources, we have a decentralized network, and it's public-private cooperation. We're talking about private for-profit and private non-for-profit. And if you have some kind of collaborative governance and you don't have resources, you have the distributed network that we just looked at. So the evolution of the system in our country is something like that. Went from a centralized network to something completely disaggregated during the Civil War. Then we bounced back to a decentralized network. And what I'm saying just now, it is very possible that we are evolving toward a distributed network. So now we shift a little bit to my question of scenarios. When you're looking at the future, you have two ways of doing that. You say, finally, I'm able to analyze the situation. I know what the future would look like. I'm going to plan and head according to the planning. Well, companies are using that. Planning is one of our tools. And then you have the situation where you are in a very messy situation, very ambiguous situation. You don't understand really what is happening, and you need some direction, and this is why when we use scenario. So what you try to do with scenario is just to have alternative views of the future. It's a lengthy process. We begin by going in a lot of documentation. We read a lot just to have factors. Then then we convey and invite a think tank just to have to find what are actually the certainties and uncertainties of the system. What we look for are uncertainties. What will happen with main factors, and then we develop scenario. We did that with one of my colleague, Professor Karim Majad, for a course called Scenario Planning and Business Continuity. And what I'm going to present are the results of our work. So we found actually two main uncertainties. The first one, obviously, is about the institution. Do you have weak institution or strong institution? And we don't know what will happen. It's a main uncertainty, and we cannot say in the future in Lebanon there will be strong or weak institution. We still don't know. And the second one is about economic condition, donc meaning dollars. Are we going to have an economic collapse, or are we going to be able to control our economy? Then when you have your uncertainty, you cross them, you have a matrix, and then you name the scenario. You use the name of films to name scenarios. It's the usage. So if you have an economy under control, and when we're talking under control, we're not talking only the control of the states. We're talking about the control of eventually parties. So if you have an economy under control and weak institution, we call that mafia blues. I'm not going to go into detail. This is basically the Civil War, where the state is not there, but you have parties that are able to reap the benefit of the economic situation, and there is money. when you have an economic collapse and you have weak institution, we call that the men in black. Actually, men in black are the people that represent United Nations, etc. And we see today in our country, today, a super influence of United Nations institutions. And actually, as Lebanese, we are requesting their intervention to have some kind of order. So this is the men in black. Phoenicia is the rise of the phoenix. I think we are a little bit a dumb phoenix because we didn't understand. Each time we try to rise again and succeed. So the assumption is that we will try at one point to rise again and have strong institutions that will inject more economic dynamic. And we have a transition scenario because having strong institution and economic collapse doesn't make sense. If you have strong institution, the assumption is that at one point they are going to do something to work with the situation and better the situation. And then what we did put our configuration on that. So the war, civil Lebanese war, we have a disaggregation, a complete disaggregation of the system. We go to men in black. Actually, it's what is happening today. If we are not wrong, we have a distributed system. Phoenicia was about that ecosystem that we're talking about, and we can eventually imagine that the future solution, when the situation will better, is to go back to that kind of system. So going from a distributed situation to eventually that ecosystem. And Madam Metni, Mr. Nasr, what I would like to discuss, please, with you is